Good evening, everyone. Thank you for joining us for the third session of Child Mental Health Community of Practice, Depression, Suicidality, and Self-Harm. I would like to formally start the session by acknowledgement of country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon-wurrung people, and Wurrung people. We pay respects to elders, past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Before we start, some community of practice guidelines. We agree to stay on mute unless speaking. Raise your hand to speak. Keep conversations confidential. If possible, please keep your camera on. Introduce yourself and your role when speaking. Share ideas and promote everyone's participation. Acknowledge that we have varied learning needs and interests. Ask questions. No question is silly. And if you are not comfortable, you feel free to pop your questions into the chat box as well. During the education component, as I said, please ask questions via chat box. This session is being recorded. Please ensure that you join the session using the name you registered with so that we can mark your attendance. Certificates and CPD will not be issued if cannot confirm your attendance. Just something about how to change your name in Zoom meeting. So click on participants. If you're joining in through an app, please click on your name. If using desktop, then hover over your name and click the three dots. If using Mac, then click your name and click more. Click rename, and then you can just change your name. Our presenter and psychiatrist for today is Dr. Prakash. Dr. Prakash is a senior consultant child and adolescent psychiatrist at RCH with over 20 years experience. He has worked in and managed general and specialist clinics within child psychiatry in metropolitan and regional public mental health services. He has worked with children and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. Little bit about myself. I'm Saha. I work in Sunbury at Gunawara Medical Center, and my areas of interest are child and adolescent mental health and chronic disease management. I'm just going to hand over to Dr. Prakash now so that he can present the educational component for the night. Thank you, Dr. Prakash.
Thank you, Dr. Saha.
Would you like to share, or I can continue?
Please continue. Thank you. Thank you so much. Today's topic is the management of depression and suicide. I always say this, and I think the first step, one thing I wanted to be clear about is that diagnostic labels have much less accuracy and applicability to the child and adolescent age group compared to the adult age group. And the younger the child, the less, in fact, accurate the diagnostic labels are, particularly the adult psychiatric disorder diagnostic labels. So I'm not speaking about ADHD and autism and things like that. I'm speaking more about bipolar disorder and depression and other problems. Similarly, suicidality in children and adolescents is driven by multiplicity of factors, less by a mental illness and more by psychosocial and other vulnerabilities. So with that in mind, the first step after an assessment is to create a formulation which guides the focus of treatment, especially the psychological therapy in depression. It also helps to choose the type of therapy that is more likely to be useful for the young person, the consumer. Ratings of suicide risk based on a Likert type scale and then being classed as low, moderate, and high, which is a prediction-focused sort of model, is not particularly evidence-based. A more useful approach is the creation of a risk formulation that is based in the aim of prevention rather than prediction. We're now going away from using rating scales, however prominent they have been in the past. We're moving away from trying to rate people's suicidality using rating scales. Thank you. This is an example of a risk formulation. On the left-hand side is the clinical data, which includes obtaining information about the entire history of the young person. So not just the suicide history, but the current problems that they have, past history of treatments and how well engaged they were, their developmental history, family history that includes the transgenerational pattern of relationships between parents and children across different generations, and developmental history in detail, including the development of emotional regulation and response to moral questions, self-identity, and a whole variety of topics, not just the standard sort of speech and motor development, but lots of the other psychosocial developmental sort of stages as well. With all of that, we would also then gather the history around past history of suicidality, the means used, the number of times it's happened, how lethal they are, what was the level of intentionality in the person. Are there other risk factors like high levels of impulsivity, depressed mood, high levels of anxiety, trauma, including psychological trauma, family conflict, child sexual assault, and a whole variety of things like that. All of this information, which has two parts to it, the parts that are not changeable, called the static parts, and the parts that are more changeable, which are the dynamic parts, they are carried into the formulation. And with that, there are 4 parts in the formulation that we would write for a patient who is suicidal. The first one is called the risk status. Risk status predominantly comprises of the static parts. These are the parts that are not able to be changed, but they also help us compare that child or young person's risk with others of the same age, the socioeconomic demographics, where they live, cultural background, if they have any illnesses or mental health conditions, all of that. And also, you can compare the young person's risk with other young people you have seen in your clinic over the last week or 2 weeks. That is a much more kind of sensible way of comparing risk rather than using a random 1 to 4, low, moderate, and high, because what do you compare that with? Who do you compare it with? And the other thing is that in the rating scales, a lot of the questions that are being asked, they are not known to be directly predictive of completed suicide, which is what we are trying to assess. Who is likely to complete suicide is the question that we are trying to answer with the risk assessment. So formulation is so much better. The next part of the formulation is called the risk state, which is the person's risk now compared to their own risk in their previous history. And usually what happens is that people use what's called as a case approach, which is chronological assessment of suicidal events, CASE approach. And that covers 4 time points. From now, the previous 48 hours, the last 2 weeks, 2 months. And then the 5th time point is, before 2 months. But they generally say that anything beyond 2 months is not relevant to the immediate assessment of suicide risk. So risk state is the person's current risk compared to their own risks in their recent history. Third thing is available resources. These are strengths, positive aspects in the individual, in the family, in the community they live in, and includes both internal resources such as good levels of distress tolerance, problem-solving skills, capacity for mindfulness and centering themselves in the midst of turmoil, various other things. And people have different levels of mindfulness skills. And it's assumed that adolescents are in turmoil, which is a kind of a global statement. There are lots of adolescents who are very grounded and who can contain themselves in moments of significant crisis. So it's about measuring that and working on that and helping them with that. So the last and final thing that we would do in a formulation is to understand what foreseeable changes are likely to occur over the next few days or few weeks that are likely to increase the risk state. Is there going to be a court case? Is there an anniversary of sexual assault? Is there going to be a suspension from school, a breakup with a romantic partner, and so on and so forth? So the risk status, risk state, available resources, and foreseeable changes. The 4 of them together can form a risk formulation. Thank you. One thing that doctors can improve quite significantly and thereby reduce suicide risk significantly is insomnia. A lot of young people have insomnia due to a variety of reasons. Some young people, especially those with neurodevelopmental disorders, have insomnia for many, many years, and they're kind of hard to treat. But I think a focus on that and trying to treat it, even slight improvements that you can make to that, can reduce the suicide risk significantly. Studies have shown that sleep disturbance may be a marker of distress and lead to suicide risk. Multiple different types of sleep problems that are concurrent may confer greater risk of suicide than single sleep problems, usually. So they would certainly recommend a focus on sleep disturbance screening, suicide assessment and safety planning, sleep treatment options in the suicidal patient. There are some cognitive behavior therapy sort of modalities, and one of them is called CBTI, which is CBT for insomnia, which has got good evidence base, but it does require high levels of motivation and engagement, which some young people may not have. Melatonin is effective in young people with ASD. As you would know, there's some recent research publications that indicate that young people with ASD, children with ASD, produce an immature, ineffective form of melatonin naturally in their brain. So the supplementing with the sort of melatonin from the pharmacy, melatonin is helpful. Use of clonidine, zopiclone, prazosin, all of them can be helpful. Prazosin can be particularly helpful in post-traumatic stress disorder or trauma-related nightmares. Some people have used quetiapine as well for that. The other thing is cardiovascular exercise and treatment, and treating depression through that. Physical exercise is associated with decreased concurrent depressive symptoms, and also, that there was lots of cross-sectional studies. The association was found to be stronger. But then when it was studied longitudinally, the association was not particularly strong. So it probably has an immediate effect for a short period of time. Physical activity of increased frequency and intensity was more strongly associated with decreased depressive symptoms, compared with physical activity that was intense but not frequent. So it has to be intense and frequent. This is a clinical management flowchart from the American Academy of Child and Adolescent Psychiatry. It sort of encourages people to sort of try some cognitive behavior therapy or other sort of psychological interventions, particularly for the mild and moderate depression, and then sort of look at more adding in psychopharmacology in the sort of more significant depression. And basically, the evidence base for antidepressants, which I will talk about in a few minutes, is sort of it's not very strong, but part of that, I must say, is because there have not been many studies in children and adolescents. Formal studies and RCTs have been very few and far between due to reasons of restrictions by ethics committees and various other sort of organizations and bodies. So that has been a problem. A brief overview of psychological therapies would include firstly, looking at some psychoeducation, motivational interviewing to promote engagement in the therapy. There is a crisis intervention technique called therapeutic assessment, which has been known to be quite helpful in promoting engagement. So promoting engagement with psychological therapies is a significant thing. So most psychological therapies that have known efficacy are provided by, say, clinical psychologists or social workers with psychological therapy training or mental health nurses with therapy training over several weeks, sometimes even months. And it takes a prolonged period of time to kind of engage, formulate a plan, sort of have some alignment of goals, some alignment of the kind of emotional cohesion between the therapist and the child before launching into therapy. So some things that we can do in short sort of timeframes within a medical context or medical clinic context would be to do motivational interviewing, psychoeducation about depression and why do we think that there is a need for treatment, letting them know that kind of depression is a very recurrent problem, that if engaging in treatment now will prevent lifelong depression in the future, and so on and so forth. Routine specialist care that does not include any individual, family, or group work has also been found to be helpful. So sometimes even GPs or pediatricians seeing people regularly has also been seen to be helpful, interestingly enough. That contact, that validation, that sort of an attachment relationship with a helping professional or a health professional has been helpful. CBT has by far the most evidence-based, but that's also been the most studied. So there's numerous meta-analyses and reviews of CBT for child and adolescent depression. Computerized CBT also has sort of picked up in interest since the pandemic. There is a specific CBT intervention called CBT for suicide prevention, which focuses on risk reduction, relapse prevention, and it combines CBT and dialectical behavior therapy sort of modalities to directly treat the suicidal or depressed adolescent. There are about 12 acute sessions and 12 continuation sessions that looks at a behavioral unpacking of what happened. So a chain analysis of the suicide event, safety planning, development, skill building, psychoeducation, family intervention, relapse prevention in a stepwise kind of progression. The other ones are dialectical behavior therapy, where the young person learns that in life you have the pleasant and unpleasant, and you have to accept that as part of normal life, and they teach the person to kind of learn mindfulness skills, distress tolerance skills, interpersonal effectiveness skills. Mentalization-based therapy teaches young people to be aware of their own and other people's mental state and not misread cues from other people, assume that people hate them when they don't, or assume that they are not important to people when they are, that sort of stuff, and helping them improve their interpersonal relations with others through improved understanding of the dissonance in the way they look at the way others look at them, basically. The other one is acceptance and commitment therapy, which focuses on higher values that the person may have. It appeals to a group of young people whose fundamental problem is that they believe that they're not being taken seriously. They believe that they have higher values. They believe that they have certain values that are probably, if not equal, even superior to that of their parents or other adults. They see themselves as sort of, kind of slightly more pure in some ways on the one hand, but then also feel that they are dismissed. And so appealing to that group of sort of young people to kind of reach into their higher values and trying to live according to their higher values and accepting sensations, urges, negative thoughts, but then not attaching themselves to that, just letting the thoughts come and go and experiencing themselves as an observer of their own sort of thoughts and feelings coming and going. That's the sort of basic kind of construct of acceptance and commitment therapy. Because once you kind of work out what they have to do, then the commitment is about carrying out the tasks of sort of working on the strategies. The other therapies are called interpersonal therapy A for adolescents. It's time limited. There are acute sessions which are for 12 to 16 weeks. There's a beginning period, which is 1 to 3 weeks, a middle period, which might be 3 to 4 weeks, and an end period, which might have 3 to 4, sort of sessions. The therapist uses strategies with an interpersonal focus. So in this case, it's like it's not so much to do with why depression happens to anyone and everyone and what happens to people in depression. It's what happened to that person in their life which made them become depressed. So it's particularly helpful if people have a feeling that they have had lots of losses in their life, that it helps to create a roadmap for them to sort of map their life from the time that they can remember till now, and talking about significant events that have happened in their life and kind of discussing whether they have contributed to feelings of sadness or loss or invalidation and all of that sort of stuff. So that's the focus of interpersonal therapy. And cognitive analytic therapy really explores the person's role kind of in the world and naming the way in which the person has been related to by other people since childhood. So this again is about improving the person's relationships with others around them, significant people around them, whilst also addressing the person's internal conversations that they are having about their interpersonal relationships with people. So as you can see, a lot of these therapies are focused on trying to change the young person's perception about how they think they are being perceived by others around them and how they relate to others. Attachment-based family therapy is, kind of, the only family therapy modality that has been known to have some slight evidence base. Basically, it improves safety at home. And the way it does that is it goes back to the core of attachment-based research now, which says that even adolescents consider their parents. This is the kind of thing that adolescents always seek out friends. They don't really want to divulge their stuff to their parents. That's true, but when they are in distress, they expect their parents to come and reach out to them and support them. Even if they are not reaching out to their parents, they expect their parents to be attuned and understand that they are in distress and come and help them. So this therapy focuses on helping young people to communicate their feelings of distress to their parents, helping the parents receive that communication and respond appropriately. And in doing so, we also talk about so that when they were children, they used to go to their parents. When they were hurt, they were upset, but at some point it changed. And there's always a reason why. There was a particular moment in time or series of events or something like that. It might not necessarily be a traumatic event or a fight or an argument or something, but there was a rupture of some sort of that attachment relationship where the young person decided at some point, I'm not going to go to my parents and talk to them about it for whatever reason. It might even be something as simple as, now I'm grown up, I'm expected to solve my own problems or talk to my friends. People my age don't talk to parents about the problems. There are all sorts of social constructs that people get caught up in. Attachment research shows that that is not the case. Attachment disorder is lifelong. Separation anxiety is now diagnosed lifelong. So everyone can have attachment problems all through life, and it would be great to have some of that rupture being repaired. It's good. So attachment-based family therapy is quite helpful. In terms of medications, the studies of the effectiveness of medications come from different, famous studies like the Emsley study and the Keller study for fluoxetine, the Wagner study for sertraline, the Gibbon study that showed that adolescents can also benefit from fluoxetine in mild to moderate depression and so on and so forth. These studies were obviously criticized because many of them were pharmaceutical company funded. And initially, when the initial results were published, they apparently withheld information on adverse effects of all kinds, not just suicidality, but adverse effects of all kinds. And then there was a black box warning put, and that was around 2004-05, when a black box warning was put on the SSRI medications and then the SNRI medications to say that they increase suicide risk. I think it's important to kind of keep in mind that since then, there have been, the FDA has conducted 20 placebo-controlled studies with 4,100 pediatric age patients for 8 antidepressants. And they have noted that, yes, there can be an increase in suicidal ideation and self-harm attempts or suicide attempts when receiving certain antidepressant drugs, but not completed suicide. And they have kind of concluded that whilst fluoxetine is considered to be safe, almost all of the other antidepressants, except paroxetine, which is most certainly associated with increase in suicide risk compared to the others. The others are considered to be more or less equal now, Venlafaxine is associated with lots of adverse effects compared to the others. It's associated with more adverse effects, but it's one of those ones which I guess cautiously using it is fine in adolescents. Like this is an FDA-approved pediatric age ranges indications for antidepressant medications for major depression, which is the red. It's predominantly from the adolescents that the escitalopram is used for anxiety, OCD, and depression. Fluoxetine is used from young childhood. Fluvoxamine is used for OCD from young childhood. Sertraline is used for OCD for young children, which means that they are safe. So fluvoxamine and sertraline have been tried in younger children. They're safe. So if ever fluoxetine fails, or if you need to use a different antidepressant, then it's safe to use sertraline and fluvoxamine as well. In terms of the kind of choice of antidepressant, just a few things, and these are just my own views. They're not necessarily in any studies because studies haven't been done actually to show this. If you go back to psychopharmacology, then you find that fluoxetine binds very strongly to serotonin receptors, and it's more likely to activate. So it's good when you have depression with low motivation, low energy, you need a kind of pickup. But it can be a problem when depression is associated with agitation. The person already has ADHD, they're quite impulsive, then it's probably slightly risky to use fluoxetine. So there's horses for courses, and there's sertraline, which binds more lightly, which might be safer in that group. But you've got to pick and choose, and if in doubt, you've got to consult with a psychiatrist or somebody to sort of land on the right drug. We know the TAD study, the TORDIA study, which says that you try CBT first, then you add an SSRI. The combination of SSRI and CBT produces the best, response to the treatment. And the TORDIA study also found that non-suicidal self-injury in a child or adolescent with child sexual assault was more likely to lead to suicide attempts. And those with sort of post-traumatic stress disorder symptoms can respond more poorly to SSRIs. Some of the other drugs are agomelatine, which is a melatonin 1 and 2 receptor agonist, and a 5-HT2C antagonist. So it improves sleep, but you have to monitor liver functions because there's a history of liver injury with them. Desvenlafaxine is another one, which is used, has supposedly lower side effects compared to venlafaxine. So that is something that can be used. We need to kind of withdraw very gradually because of its short half-life. Otherwise, it might lead to discontinuation syndrome. And the main side effect is nausea, and that is usually seen in the first 2 weeks. If you get past that, that's fine. And vortioxetine, which some people, when vortioxetine came out, some people said that it was a fast-acting antidepressant, a fast-acting SSRI. I don't think it is. I think it acts at the same pace as the other SSRIs. It's used in child and adolescent depression. Duloxetine is something we have started to use now. It's an SNRI with a half-life of 12 hours, so it needs twice daily dosing, somewhat like venlafaxine, deemed to be safe in children and adolescents. It's also useful in treating ADHD in teenagers, so it's a conjoined drug with adjuvant drug with some of the other medications. Just a word on cardiotoxicity. There have been some studies have shown that escitalopram and citalopram are associated with long QTC. There have been single case reports mainly that have reported long QTC with citalopram and escitalopram. There is not enough justification to do an ECG for everyone that you choose to start on citalopram and escitalopram. It's good to get a cardiac history for sudden deaths and possible QTC. If you have any doubts, then it's good to do an ECG. But what I'm saying is that it's not necessarily something you have to do because there's a definite risk. Transcranial magnetic stimulation is an interesting kind of new treatment, which is now becoming available to adolescents in some private hospitals in Melbourne, including the Albert Road Clinic, and some adolescents are being treated through the Delmont Private Hospital in Burwood, and the Melbourne Clinic as well. So TMS is a non-invasive brain stimulation. Sessions usually last for 30 minutes. A course is 20 sessions over consecutive weekdays. So it is pretty intensive. So 20 days daily treatment. It has antidepressant effects if applied over the frontal areas of the brain, which is where they apply the sort of TMS for depressed young people. The Origin Youth Health team is actually undertaking studies now with TMS, with adolescents with depression. Some references which you might find interesting and useful.
Thank you so much, Dr. Prakash.
Thank you.
All right, so we'll move on to our next part of the session, where we will have a look at some health pathways slides. Not exactly slides, but the health pathways themselves. So I'm just going to share my screen and then we'll have a look. So if you guys are not familiar with health pathways, they cover, variety of topics that you come across in your day-to-day practice, have extremely valuable resources that are available there that you can have a look. When I was, having a look at depression in children and adolescents, there were some really good things that came across, particularly this one where they were talking about child well-being continuum. So I'm just going to share that. I think it's a handy tool to actually print, because as Dr. Prakash was mentioning earlier, that, in terms of risk formulation in general, where we can actually have a look at various aspects of the child and their relationship with their family, how things are going and what their sleep patterns are, to basically have a comprehensive assessment, and can share it with the family as well. Just trying to see, sorry. I have to stop share and share again. So it also links quite a lot of useful resources around, how to make referrals, what referral pathways are available, mood and feeling questionnaires. Dr. Prakash, do you use mood and feeling questionnaires in practice? Would you recommend GPs to use them? So I was having a look at this child self-reporting questionnaire. So in summary, I think it's a good tool to have a look at, and, quite easy to print some resources and share with family, and just helpful with the assessment as well.
Yeah.
So,
I agree that these are good tools to use. They are good to kind of measure the severity of the symptoms, and you can do them. You can give it to them, to the families, to do when they're waiting outside. And you can remind the families to actually ask for it from the reception staff and do it outside. It does not take much time. When they're waiting, 10 minutes, 15 minutes, and then they come in, you have a quick look at it, and you can compare with the previous one, just to kind of get a more objective view of the severity of the symptoms.
Thank you. Let's move forward to case